So the topic given to me today is viral hepatitis in children. So what we'll do is that we'll try and divide by two groups. One would be acute viral hepatitis. That means you have an acute infection and it gets resolved on its own or by spontaneously or with some treatment. And second would be chronic viral hepatitis. So we all know that acute viral hepatitis most commonly would mean hepatitis A and E, and rarely some non-hepatotropic viruses. That means who are not very common, but when you have a specific scenario, say there is a dengue epidemic, then dengue virus can also infect the liver. So most commonly acute viral hepatitis would mean. As I was mentioning, these are the group of viruses which usually infect the liver. So most common viruses that we see in clinical practice are the hepatotropic ones. Hepatotropism means that they specifically like to infect the liver, but the non-hepatotropic ones can also infect the liver, but these are mostly multi-system disorder than in which liver is a secondarily infected organ. So most commonly in clinical practice, we deal with hepatitis A and E as part of the acute viral hepatitis, and hepatitis B, C, and D are usually in the compartment of chronic viral hepatitis. Non-hepatotropic viruses are commonly not very common in clinical practice. They are usually restricted to specific conditions like say someone is immunocompromised, in which you will see cytomegalovirus or Epstein-Barr virus uh, in clinical practice. But parvovirus and other, these are all manifestations in which you will find these are not very common. But once you have excluded the viruses which are in the hepatotropic category, you always have to look for non-hepatotropic viruses, especially if there is a clinical condition. So, for example, if you see a patient who has come with jaundice and there is say a dengue epidemic going on. So if especially if you find say thrombocytopenia or other features of dengue virus, you will start investigating once the markers for hepatotropic viruses have come out to be negative. So we'll focus on acute viral hepatitis and chronic viral hepatitis separately. Acute viral hepatitis, most commonly in clinical practice, if a patient has come to you with jaundice in an acute setting, you will suspect acute viral hepatitis. And in India, most commonly, I've compiled a series here. Uh, Hepatitis A is the most common cause of acute viral hepatitis in children. Almost 50 to 80% of cases of acute jaundice in a child in India is caused by hepatitis A. Second most common is hepatitis E, followed by hepatitis B, which constitute about between 10 to 20% in each of them. So hepatitis A will focus on hepatitis A and E almost in simultaneously. Uh, it's a resistant virus. It can tolerate heat and cold storage for weeks altogether. But the most important thing is for both hepatitis A and E, since we know these are both water and food-borne disorders, if you heat your food or you for more than 85 degrees or you properly boil it, you properly boil your water, then these hepatitis A and E, these get inactivated, they get killed. So the most important thing, how you prevent hepatitis A and E, if you drink clean water and if you eat properly cooked food. So these are the only two simple measures that can help you prevent viral infection by hepatitis A and hepatitis E. So as I've already mentioned that hepatitis A is the single most important etiological agent for pediatric liver disease in the country. That means the most common cause of acute liver failure, most common cause of acute viral hepatitis is hepatitis A in children. For how do these acute viral hepatitis present, both hepatitis A and E? There is an incubation period in which the virus enters the body and then it starts multiplying. When the viremia occurs, there is a first phase which is known as prodrome. Prodrome is nothing but that before you start seeing jaundice, before you start seeing yellow eyes and urine, a few days before that, the patient would start feeling ill. They would have decreased appetite. Anorexia is the most important component. There would be some fever, some vomiting, some abdominal pain, lethargy, myalgia, weakness. So this is how we always ask the patients that if you had any of these symptoms just before you experience jaundice. So if the patient tells you that he has a prodromal kind of illness, we suspect an infective hepatitis in the first flow. Then jaundice develops, and mostly it is always with a dark urine because it's a conjugated type of jaundice. And usually in all viral hepatitis, hepatitis A and E, they get resolved on their own spontaneously in majority of the patients within 3 to 6 weeks. So any patient, अगर आपके पास कोई patient आता है who tells you that I've got jaundice and you suspect and clinically or you diagnose them as hepatitis A and E, you can tell them clearly that 99% of them, I should not be telling you figures, but vast majority of them will improve on their own within 3 to 6 weeks. 1 से 1.5 महीने में mostly improve हो जाते हैं. आप कोई treatment दे या ना दें, spontaneous improvement होती है because the immunity takes over. Now, why do we, if you test for these hepatitis A and E and it comes out to be negative, then you will have to look for non-hepatotropic viruses, as I was mentioning earlier. अगर किसी पेशेंट को रैश हो रहा है बॉडी के अंदर, कोई रेडनेस है, मल्टी सिस्टम इन्वॉल्वमेंट है, लूज मोशंस है, वॉमिटिंग्स है, कफ है, सोर थ्रोट है, लिम्फेडिनोपैथी है, these are not features of hepatitis A and E. These means there is some multi-system involvement everywhere. So every organ is affected, upper respiratory, lower respiratory, GI, skin is involved. This tells you that there is some non-hepatotropic viruses which is playing into consideration. Then you will have to go specifically for serologies or PCR-based tests for these disorders. Though these are not commonly available everywhere, but these you start investigating only and only when your hepatitis A and E serologies or blood tests come out to be negative. Then you will have to find out if it is available, if the lab tests are available, you can always send these. Hepatitis E also present in the same way as hepatitis A. The important point to note in hepatitis E is that it has got a higher risk of liver failure in pregnant women. The etiology and pathogenesis is still not clear, but they say that compared to hepatitis A, if a pregnant lady suffers from hepatitis E infection, there is high likelihood that she may go into liver failure. But the incidence of liver failure in a patient who has hepatitis A and E, of a patient who has developed hepatitis A to go into liver failure is less than 1%. It's very minuscule. So if you see hundreds of patients, you will find just 1 or 2 odd patients who are actually going into liver failure because of hepatitis A and E in children mostly. But pregnant women, this incidence goes high. Hepatitis E can also get superimposed on an underlying cirrhosis or chronic liver disease. So that is the term which is known as acute and chronic liver failure, but it's out of the purview of this PPT. I'm not going into in details further. So I have already mentioned for both hepatitis A and E, risk of liver failure from developing a liver failure after viral hepatitis is very less. It's less than 1%. You may call it 0.1, 0.2, whatever percentage you want, but it's very less. Some of them may suffer from atypical manifestations, like jaundice may persist for months altogether. So it may go beyond 3 months, 6 months, 9 months, even 12 months. Sometimes jaundice can persist. You may not find any cause, and they will spontaneously resolve over multiple times. They may have a relapsing course. You suffer from jaundice one time, you recover within 3 to 6 weeks. Then again, after a few days, the jaundice may reappear. This is a relapsing pattern, which is most commonly seen with hepatitis A rather than hepatitis E. They may develop some mild ascites. They may develop severe anemia, which may be because of a virus infection or because of underlying associated G6PD deficiency. When do we worry? I've told you that majority of them would improve on their own. But when you see these signs, then you start worrying. The patient has developed features of encephalopathy. He's become lethargic. There's increased sleepiness. There is persistent vomiting. There is some bleeding on the side. Fever, he started developing fever. He started developing altered sensorium or seizures. There is cola-colored urine. There is significant hemolysis going on. The body, there is anasarca or the abdominal distension starts happening. Then you start worrying that we may be dealing with some other complication for that, and you need to refer these cases at the earliest. So how do you diagnose them? I've told you the most common viral hepatitis are hepatitis A, B, C, and D. A, B, C, and E. So you have to send serologies for all of them at the same time. Don't just have one serology and then wait for the result to send another one. If you have to save your time, you have to do all these serologies at the same time in a given patient. For both hepatitis A and E, first the IgM antibody develops. That is how you diagnose them. That is the test for doing hepatitis A and E, IgM-HBV or IgM-HBV. Then IgG antibody develops. It gives almost lifelong immunity from hepatitis A, less commonly with hepatitis E. That's the same scenario with hepatitis A. I told you that first the IgM serology develops, then IgG develops, which gives lifelong immunity for hepatitis A. How do you manage them? I've told you that majority of them would improve on their own, even if you don't do anything. So even if they don't visit a doctor, most of the patients of hepatitis A and E, the jaundice would recover on their own within 3 to 6 weeks. So you don't have to restrict any diet. There should be a normal diet, plenty of fluids, no medications are needed in majority of them. So there should be no restriction on diet, no bed rest is needed. They want to run, let them run. They want to play, let them play. Children are children. You cannot ask them to lie down on bed if they are feeling well. There should be no restriction of namak, tel, ghee, haldi. If they want to eat a good home cooked, say pakode, they want to eat pakode, they want to eat jalebis, whatever you want. If you want to cook it at home, you're going to clean it, the hygiene is good, they can eat anything. So no namak, tel, ghee, haldi ka parez. Everything they can take it. You don't restrict them. Don't give them any herbal medications. I would say there is no need of any allopathic medication also. No allopathy, no homeopathy, no Ayurvedic, no Unani medication is required. Majority of them would improve on their own. Even if you give them, there is no risk, there is no benefit that you will prevent. Say if you say I'll prevent the jaundice from worsening, or I'll prevent liver failure in this patient. No medication can help you prevent a liver failure if it is going to develop. So there is no medication intake needed, no Glucon-D, no sugarcane juice, nothing is required. If you try giving them Glucon-D, the side effect is they start vomiting. The gastritis, Glucon-D, if you try and push in more, it induces gastritis and it induces more vomiting. So you must have seen many patients, you start giving them Glucon-D and these things, they worsen their condition because they develop gastritis and they will start repeated vomiting. Once you stop Glucon-D, their vomiting stops. So be careful. You need not do anything in them. Just counsel them. Just ask them to keep under regular follow-up to ensure that if they are developing liver failure, you may be able to pick it up early. No medications are required. No restriction of diet is required. No bed rest is needed. Specific treatment for viral hepatitis is only restricted for few conditions, say for severe hepatitis B or other HSV or varicella or CMV, but these are not very commonly encountered in children. For hepatitis E, some viral measures like PEG interferon or ribavirin are available. These are mostly but have been used in patients who have an underlying cirrhosis, not commonly in for hepatitis E infection. So next we'll go through chronic viral hepatitis. I've already mentioned that the two most common viruses which can develop chronic viral hepatitis. Chronic means that once they have infected the body, they would remain in the body for long period. Long period. What do you mean long period? The common definition that we use is more than 6 months. So if the test for hepatitis B and hepatitis C is continuing to be positive even after 6 months of follow-up, you call them chronic viral hepatitis. India has almost 1/10 of the global hepatitis B pool. So that means every 1 out of 10 hepatitis B positive patient in the world is an Indian. We have got a very high prevalence rate for hepatitis B, almost between 2 to 4%. That means 2 to 4 out of every 100 Indian has got an hepatitis B infection in them. So the most important thing is that this means that you may have hepatitis B patient in and around you, in your family, among your friends, your relatives, everywhere. You may not be able to diagnose them by looking at their face. They may be absolutely asymptomatic all throughout their life. So most important thing is that you have to suspect if a patient has got a hepatitis B. So I say everybody should get themselves tested for hepatitis B and hepatitis C, especially if they are belonging to high risk groups. What are high risk groups? Suppose if you have a family history that somebody is suffering from hepatitis B or hepatitis C, it's your duty that you should get yourself tested. You may not know that you may be carrying these infections. If you belong to some high risk group, say if you see a child in your family whose mother is hepatitis B or hepatitis C positive, you should always get that child tested, and the entire family should test. If you engage in some high risk behaviors like unprotected sex, there has been there's a blood transfusion in the past in which you're not sure whether the quality was good, or there was some IV drug abuse, if there was some operations in which unsterile practices were used. These are the conditions. If anybody in and around you, even yourself, have suffered from any one of these risk factors, it is your duty to convince or to encourage everyone to get themselves tested for hepatitis B and hepatitis C at least, so that you can diagnose them before they clinically start manifesting them. Hepatitis C is less commonly seen in India. The overall prevalence is less than 0.1 to 1% overall. So for hepatitis B and C, the most common route in India is perinatal transmission. That means the mother transmits the virus to the child. That is the most common for hepatitis B as well as hepatitis C. Uh, this is major route in developing world. In adult, the developed world, its major route is sexual transmission. Other routes like IV drug abuse, blood transfusion, hemodialysis are relevant in specific conditions only. So for hepatitis B or hepatitis C or HIV, it does not spread through food and water. It does not spread through eating together. It does not spread significantly through breastfeeding. With casual contact, it does not spread. You can hug them, you can touch them. There is no risk factor with that. It does not spread through coughing and sneezing. So don't worry if we've been telling this for decades and decades altogether. Because if you can stand with the hepatitis B, you can have a casual contact with them. You don't have to discriminate these people just because they are carrying hepatitis B, hepatitis C, or HIV infection. These three viruses, they do not spread through these things. So be very comforting to these patients that you should not be discriminating against them. That once you find someone in your family or among your relatives or among your friends, that is the reason that we always tell them that do not discriminate them. It's not their fault that they got this infection. It's maybe somewhere because some unfortunate incident this might have happened, and so they need not worry. Do not discriminate them, please. So these are the high risk groups. That's what I'm telling you, that if somebody or you yourself, your family, your friends belongs to these high risk groups for both hepatitis B and hepatitis C, you should always encourage them to get themselves tested. If the mother has been infected, they are engaging in high risk sexual behaviors, they have been in the past or in the present IV drug abusers. If you are a household contact of a patient who has got hepatitis B, say you're in close contact, you are dealing with them physically contact every now and then you should get yourself tested. Healthcare professionals, because you will be dealing with all these patients all around you, and if you are infected, you are always a risk to your patients. If there is say a finger prick or something like that, every healthcare professional, even if they do not suffer from these high risk, they are not included in these high risk groups, they have a duty to get themselves tested for hepatitis B and C and HIV also. I would say once in a lifetime, at least you should get yourself tested. You may never know where you might have picked up this infection. Hemodialysis patient, definitely they should get themselves screened routinely. So hepatitis B, I'll not go into much detail. But for hepatitis B, they say that the virus, once it enters into your body, it passes through certain stages. So immunotolerance stage, immunoclearance stage, inactive carrier stage, or reactivation. These are the stages. In children, mostly 90% of them are in immunotolerant or inactive carrier state. So this means that majority of them do not require any treatment. In adults, it's a different ballgame altogether. But children, majority of them, only 1 out of 10 any of hepatitis B patient actually requires a treatment. So let me emphasize this point again and again, that majority of children, if you come across a child who has suffered, who comes with a positive report of HBsAg positive, please refer them to a pediatric gastroenterologist or hepatologist before starting any antiviral treatment. We see many prescriptions in the a physician looks at the HBsAg report and they start them on oral antivirals, which they must have learned from adult people, and they then send us the referral that now we have started this treatment, now you manage. So let me tell you again and again, pediatric infection with hepatitis B, it's an art of a patient in which you do not have to give any treatment at all in 9 out of 10 patients. In 9 out of 10 patients, you just have to follow them up, because the treatment is not going to be effective in the stage in which the patient is in. So only 1 out of every 10 pediatric hepatitis B patient actually requires any treatment. So this is not for, it's better to take a referral from a pediatric gastroenterologist or hepatologist, because children are not adults. If you start an oral antiviral of them, they have got life ahead of them for 10, 20, 30, 40, 50, 60, 70 years. They are not 40, 60, 70-year-old adult. If you give them 5 years or 10 years of oral antivirals, their life is over. If you start an oral antiviral without any indication in a 5-year-old, 10-year-old child, how long do you think that he can keep on taking the medication? Especially when the treatment was not indicated at all. So please, I request everyone that you should realize that uh, treating children for hepatitis B is not an easy game. It's always an art to decide whether or not they require any treatment at all. So I would request everyone, if you encounter a patient who has got hepatitis B positive status, it's mandatory that you take a referral from a pediatric gastroenterologist or hepatologist. There, every government hospital, especially I'm working in Delhi NCR, so I know at least in this area, every government hospital has got a good pediatric gastroenterologist and hepatologist. They are working everywhere in private setup also. So there is no harm in taking a referral from a pediatric gastroenterologist or hepatologist before you start any treatment in them. So mostly in children, I've already mentioned it is a perinatal transmission. So if the mother is infected, she will transmit the virus to the baby. There is a difference in that. So if the mother transmits the virus to the baby, there is more than 90% chance that that child would develop chronic infection. That means the virus, once it enter into the body, it will remain for his lifetime. But if you and I get an infection, suppose we are not vaccinated, suppose I'm not vaccinated, I suffer from a finger prick or a needle prick from a hepatitis B positive patient. Even though I am not immunized, even though I have not been vaccinated, there is only 5 to 10% of chance that I will suffer from chronic viral hepatitis. My immunity will take over. That more than 90% of the infection, even if I develop jaundice, my body will take care of that infection and my body will not allow that virus to remain in the long term. So I'll not suffer from chronic viral hepatitis. But in children, it is different. They have a higher risk of developing chronic infection. So another important point is, once hepatitis B virus enters into your body, it will never go away. I will emphasize this point again and again. There may be some allopathic practitioners, some homeopathy practitioners, some Ayurvedic practitioners, some Unani practitioners who may tell you that we'll do give you some medication and the virus will take out the virus and virus will disappear from your body. There is no treatment, no proven treatment as of now in world literature which can tell you that virus completely goes away. Even with our allopathic medications, the virus, you can decrease the level of virus, but it will never go away. It gets sequestered, it hides in the liver, and it will never go away from your body. But it does not mean that it will cause any harm. So that is why we'll say that the follow-up is important in these patients. So the viral levels may go down, but it will never go away. So you'll have to be following them up for their lifetime. So that is why every time we encounter a patient, the most important thing we emphasize them that we may or may not give you any treatment, but the most important thing is that you follow up regularly every 6 months to 1 year, whatever the duration the gastroenterologist decides. So it's a lifelong disorder. As of now, in the current literature, in the current medication list, there is no permanent cure for hepatitis B as of now. So most important thing in chronic viral hepatitis for hepatitis B in children, that majority of them do not suffer from any clinical disease. They may be HBsAg positive, but most of them are doing well. There is only very limited risk that they may develop chronic liver disease or cirrhosis. Only 1 to 5%, less than that. So majority of them, that is why we say that in children, virus is not going to damage the liver. The risk increases significantly when they enter into adulthood, but most of them will do well. You just have to follow them up, and they only require treatment in specific conditions when the liver tests start worsening or you following them up, they develop jaundice and all that. These are all only limited indications in which you actually give any treatment. Drugs are available in which you can try and decrease the viral load, try and control the virus, but it cannot be cured as of now. There are pegylated interferon injections are available, and some oral drugs are available like lamivudine, entecavir, and tenofovir, which we use if the need arises. But who is going to decide which child needs a treatment? It should always be in consultation with a pediatric gastroenterologist or hepatologist. Family screening is most important. That means if you have picked up a patient, adult patient or a pediatric patient who has come to you with HBsAg positive report, it's mandatory that you tell them that all first degree relatives, at least your parents, their siblings, their children, should get themselves tested for hepatitis B. If they turn out to be negative, they should be vaccinated and their titers should be checked so as to ensure that the seroconversion has taken place. Hepatitis C is a different ball game somewhat. They say that even if you get infected, the most common source is mother-to-child transmission. Even if you get infected, almost 20 to 25% will clear the virus within first couple of years of life. So in children, we do not start any treatment for hepatitis C at least before 3 years of age, unless there is some liver damage going on, LFTs are worsening, something like that. That is a rare scenario. So before 2 to 3 years of age, we do not start treating hepatitis C because 20 to 25% may clear up the virus on their own. The diagnosis is based on anti-HCV and HCV RNA later. Now, for more than 3 years of age, there are previously we used to give PEG interferon injections for 24 weeks, 48 weeks, weekly, even daily injection we used to give. They used to be painful. They used to have lots of side effects, and even the efficacy was low. But for last 5 years or so, drugs have come up. Hepatitis C treatment has changed tremendously for children and adults. Now, permanent cure is available for hepatitis C. More than 99 to 100% success is now being seen for hepatitis C in adults and children. In children, some of drugs have been approved for more than 3 years of age. These drugs or combinations are available, in which drugs are given for 12 to 24 weeks based on the condition, based on the genotype. And that is how, and if you have taken the drugs properly, more than 99 to 100% success has been now being seen even in children also. So hepatitis C game has changed. Now permanent cure is available, but the scenario is not the same for hepatitis B. How do you prevent though? So there is no permanent cure for hepatitis B. Therefore, we always say that vaccination is the cure. All patients should be vaccinated against hepatitis B. As a gastroenterologist, we always tell them to get vaccinated against hepatitis A also, because it's one of the vaccine preventable diseases. And when you see patients dying of hepatitis, acute liver failure because of hepatitis A, young children dying of that, you always realize that if they had taken a hepatitis A vaccine dose, they could have been saved from these. So as a gastroenterologist or hepatologist, we always tell them everyone should get themselves screened for and get themselves vaccinated against hepatitis B and hepatitis A. Hepatitis B vaccination is almost absolutely effective for both hepatitis B and hepatitis A. For pregnant women, it is important because we always tell them that the mother to child transmission is the most important source for hepatitis B. So you have to decide that you have to break this cycle. You have to prevent the infection from going from the mother to the child. So how do you prevent them? The most important thing is you need to give birth dose of vaccine, followed by complete the course of vaccine within 12 to 24 hours of birth. You have to decide whether you need to give hepatitis B immunoglobulin. If the mother is highly viremic, the viral loads are high, the gastroenterologist may even decide to start oral antivirals in the mother while she is pregnant by 28 weeks of age, 28 weeks of gestation. So these are always to be done in consultation with a gastroenterologist or hepatologist. So with these measures, there is very limited risk, less than 5%, 10% risk that even if the mother is positive, the child may get infected. So you have to give vaccine. That is the most important intervention that you can do. Even if the immunoglobulin is not available, vaccines are good enough to prevent infection transmitting from mother to the child in majority of the scenarios. Elective cesarean does not prevent. Breastfeeding, very limited risk of transmission. Therefore, for hepatitis B, for hepatitis C, for HIV, we always tell the mother to give breastfeeding. It is a cost-effective measure. The risk is minimal. Exclusive breastfeeding is the norm for both hepatitis B, hepatitis C, and HIV also. So exclusive breastfeeding should not be mixed feeding. There should be no controversy regarding that. So even if you do not give any prophylaxis to the child, there is very limited risk of transmission from hepatitis B positive mother to their breastfed infant via breastfeeding. So breastfeeding, it has a lot more benefits than the risk. So therefore, risk-benefit ratio, cost-benefit ratio, it always tells us that exclusive breastfeeding should be practiced in mothers who are infected from hepatitis B, hepatitis C, or HIV. You should be in consultation. You should always consult a gastroenterologist if you have any doubt with that. Vaccines are available for hepatitis A also. There is the killed vaccine in which you have to give 2 doses, and there is a live vaccine in which you give single dose after 1 year of age. Excellent efficacy is there, and safety is good. This scenario, previously we used to believe that hepatitis A is endemic in our in India, and majority of them used to get infected. Even if they did not develop any jaundice, they used to get subclinically infected by this hepatitis A, and majority of them would develop protective antibodies by 5 years to 10 years of age. But scenario for last few decades has somewhat changed. So there are some pockets in which you get natural infection because you are exposed to this virus by bad food or bad water. But there are some upper middle class or upper class societies in which you will never get exposed to this. So unless you get infected, you will not develop immunity against them. So in these pockets, in a middle class or higher class societies in which you are not being infected, you are not naturally protective against these. Their epidemics have happened, and therefore this epidemiological transition is going on in current scenario. Therefore, we as a gastroenterologist, we always tell that vaccination should be a routine. Hepatitis A vaccination should be a routine, and you should, as required, hygiene and sanitation should be improved. Hepatitis C vaccine, there were some clinical trials were done more than a decade back, but it's not in commercial use as of now. So to summarize, the most common cause of acute viral hepatitis in children is hepatitis A. You should always exclude all these 4 viruses, hepatitis A, B, C, and E, in every cases of acute viral hepatitis. Complete evaluation is important. You may suffer from co-infection. Hepatitis A may co-infect with hepatitis E. Hepatitis A may co-infect with hepatitis B. So all these 4 tests should be done simultaneously. Acute viral hepatitis, there is no need of any treatment, no need of any dietary restrictions, no medicines. Reassurance is the key. You have to screen family and the high risk groups, and you should always get themselves tested for hepatitis B and hepatitis C at least. Thank you so much.